Hello, and welcome to our SEDSConnective presentation with Dr. J Eccles on long COVID and hypermobility. SEDSConnective stands for Symptomatic Hypermobility, EDS, HSD, Neurodivergence. We started in Sussex, but we're now a global user-led voluntary charity. I'm Jane Green. I'm an educationalist, founder and chair of SEDSConnective, and also keynote speaker for neurodivergence and hypermobility. I'm not a professional host, so do bear with us. We have a lovely team supporting us today as usual. So we're absolutely delighted to have Dr. Eccles here today, following the latest findings from a study which was published in the BMJ Public Health with the British Sussex Medical School and the King's College London researchers. And this found that people with hypermobile joints were about 30% more likely to say they hadn't fully recovered from COVID-19 than those without. Anyway, I will introduce her now and she will explain much more. She is a consultant psychiatrist in the Neurodevelopmental Service at Sussex Partnership NHS Foundation Trust. Having trained in medicine at the University of Cambridge and Oxford, she completed integrated academic training in psychiatry at Brighton and Sussex Medical School, where she undertook an MRC clinical research training fellowship. She is now a reader in brain-body medicine at the BSMS Department of Clinical Neuroscience, where she leads prize-winning research on a broad range of projects that link differences in the body to a variety of physical and mental health conditions. And she is particularly interested in the emerging link with neurodivergence. She is a passionate educator and committed to public engagement. So I now want to welcome Dr. Eccles to our meeting, and we will go ahead. And thank you all for joining us today.
What we're going to do is I'll talk probably for about 35-40 minutes, and then we'll take questions. And yes, I hope you find this useful and interesting. So my philosophy, slides won't go forwards. Let's try. My philosophy is stolen here from another academic. No, I saw this in the Guardian and I thought this is so important. So this is from Professor Edward Bulmore, who works in the field of immunopsychiatry, the overlap between the inflammatory system and mental health. The big idea, should we drop the distinction between mental and physical health? The current false dichotomy, so the current false distinction, holds back research and stigmatizes patients. I would say not only does it hold back research and stigmatize patients, but it also hinders clinical practice. And I'm sure many of you will relate to the difficulties of being stuck between mental health and physical health care. So I hope, well, I don't think I'll probably have to introduce hypermobility to many of you, but for those of you who are not quite sure what hypermobility is, this is a physical manifestation of hypermobility that everyone can see. So, for example, when I was at medical school, I was told on a ward round that I had knees, like the top right-hand picture there, sway back knees. There are other things, fingers that bend upwards. That's not in the diagnostic criteria, but is a sign of hypermobility. Being able to put your thumb back on your wrist, elbows and knees that bend backwards, and being able to put your hands flat on the floor without bending your knees. And typically children and even some adults sit in what is called the W position. But as we will go on to discover, this physical manifestation of hypermobility is a bit of a red herring, in that there are so many things, both strengths and challenges, that are associated with hypermobility, that that focusing just on the joints is really not enough. So hypermobility is far more than having flexible joints. It's relatively common, and we kind of need to distinguish between the presence of hypermobility and the presence of hypermobility and having symptoms. So I often talk about symptomatic hypermobility. And SEDSConnective often talk about symptomatic hypermobility as well. So hypermobility in and of itself can be advantageous. I mean, there are certain things that only hypermobile people can do. Certain piano pieces need to be played by hypermobile fingers. There are maneuvers in gymnastics and ballet that are really only possible if you are hypermobile. But unfortunately, hypermobility is also linked to a variety of medical issues. And because hypermobility is related to differences in connective tissue, and connective tissue is everywhere in the body, these issues cross systems and involve both body and the brain. And one of the real problems, well, I think it's a problem, and it's hindering both clinical and research work, is there are so many names and diagnostic criteria associated with hypermobility that people get a little bit confused. So there's GJH, there's GJL. They are generalized joint hypermobility and generalized joint laxity, which is just, you know, do you have hypermobile joints? But then there are different cutoffs and different people use different cutoffs. There's JHS, there's EDS, there's HEDS, there's EDS-HT, there's EDS type 3. The list goes on and on. There's BJHS. And it means it's alphabet soup, basically. And it means interpreting the research findings can be hard. And it also means that patients and doctors and policymakers are somewhat at a loss about whether all of these things are connected and what they're talking about when they are talking about a particular thing. So for the purposes of this, I will try and make clear when we talk about hypermobility, whether this is just generalized joint hypermobility or whether this is symptomatic hypermobility. So what's really crucial, the way we measured hypermobility, and I'm going to talk about it in more depth in the long COVID study, was through a self-report questionnaire. Now, this self-report questionnaire is the Hackham and Graham questionnaire from 2003 and is basically a screening tool for the Baton scale, which is a way of measuring joint hypermobility. So it doesn't indicate symptomatic hypermobility. It indicates the presence of joint hypermobility. So can you now, or could you ever, place your hands flat on the floor without bending your knees? Can you now, or could you ever bend your thumb to touch your forearm, which is like this? Can you, as a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? Do you consider yourself double jointed? So typically, if you score 2 or more, it's that's indicative of generalized joint hypermobility. Now, of course, COVID has helped us understand the idea of false positives and false negatives. So it's possible to score on this questionnaire and not have significant hypermobility, just as it's possible to not score on this questionnaire and have significant hypermobility. So just like if you do a lateral flow test and it's negative, it doesn't mean to say you don't have COVID, and it could be positive and you don't have COVID as well. Do you see what I mean? Now, this is a slightly old slide from when I was doing my PhD, but essentially you can see that hypermobility is associated with a huge number of medical conditions across systems. So things like fibromyalgia, dystonia, soft, smooth skin, stretch marks, gum problems, hernias, easy bruising, a whole host of gastro problems, reflux, gastritis, unexplained abdo pain, also inflammatory bowel disease, urological and gynecological problems, ocular problems, so being short-sighted, having a squint, dental problems, temporomandibular joint pain. And then where my work and our work at BSMS has come in is in the neuropsychiatric field, really. So things like dysautonomia, clumsiness, proprioceptive dysfunction, fatigue, anxiety, sensitivities, so sensitivities to pain, smell, and sound. So it's really been quite a series of light bulb moments working in this field. So I came to BSMS in 2009, and we started work then on a brain imaging project in response to the emerging literature between hypermobility and anxiety. And we've been working in this field ever since. And there have been all sorts of connections and interesting things found that have ultimately ended up linking together. So when we did the brain imaging study published in 2012, we found that there were differences in the brains of hypermobile people in key areas of emotional brain, such as amygdala. But we also found differences that were related to things like dyspraxia, and also were similar to differences found in neurodivergent. Increasingly, when looking into hypermobility, became interested in the overlap with fibromyalgia, of which there were a few studies suggesting that many people who had a diagnosis of fibromyalgia were also hypermobile. So this is just to remember about hypermobility. So this is back a few years ago, myself and colleagues at BSMS, including Professor Kevin Davis and Professor Critchley, we designed and were funded to do a study looking at mechanisms of pain and fatigue in fibromyalgia. And what we wanted to do was see whether there were biological things particularly related to the autonomic nervous system. So the autonomic nervous system is the involuntary nervous system. Some people have a problem with their autonomic nervous system called postural tachycardia syndrome. So we wanted to see if that contributed to pain and fatigue. And we were also interested to see whether differences in inflammation also contributed to pain and fatigue. So we designed a study where we brought people in 3 times, once to the hospital in Brighton, where we had our tilt table set up, and people, oh, where's the first slide? Yeah, sorry, the first slide. We brought people into the hospital, and we took baseline measures of pain and fatigue. We took some bloods, and then we tilted people, which is a challenge to the autonomic nervous system. And when we designed the project, we hoped to recruit a certain number of people with fibromyalgia, and as a comparison group, a certain number of people with ME/CFS, and a number of people with both conditions, and then a number of people who had neither condition. And so we brought them to the research facility at the Royal Sussex County Hospital, and they had some bloods taken. These are basic bloods called CRP and ESR that GPs are able to do, bedside blood, not bedside, but, common routinely done measures of inflammation. And then people came to our brain imaging center, where again, we measured baseline pain and fatigue. And on one occasion, everyone came twice. On one occasion, they had a typhoid vaccination, which is a challenge to the inflammatory system. It promotes a response similar to a cold. And then when they came on another time, they had a saline vaccination. And now neither they nor the researchers knew which vaccination they were, not saline vaccination, sorry, a saline injection. This was double blind. So neither the patient or the researcher knew which they had had on which day. And we did a number of measures, including brain imaging, and gene expression, and inflammatory cytokines. Now, we published this in 2021, and what we found was we had recruited 65 patients, and a third of them came to us with a diagnosis of fibromyalgia. To be a patient participant, you needed either a fibromyalgia or an ME/CFS diagnosis. And about a third of them came with an ME/CFS diagnosis. And then another third actually had diagnoses of fibromyalgia and ME/CFS. But what we found was that of those 65 patients, Zoom, things have moved around. Here we go. So what we wanted to do was to see whether having hypermobility, now this time this isn't symptomatic hypermobility, we're just using that 5-item questionnaire, was a risk factor for not recovering from COVID, which is essentially a bit like long COVID. It's not identical. There will be some people who have not yet recovered from COVID who won't stay having long COVID. But that was how we analysed it. We used something called the COVID Symptom Study Biobank. And what we found was in that sample, there were just over 3,000 people who'd been infected with COVID. Unfortunately, for generalizability purposes, the vast majority of those participants were female and white, with a mean age of nearly 60. And they all completed a self-report questionnaire to detect generalized joint hypermobility. And what we found was that having hypermobility was not specifically associated with catching COVID. So it wasn't that the people who caught COVID were more likely to be hypermobile than the people who hadn't caught COVID. But what we were wondering was whether they were more likely not to have recovered from COVID. And we also, as part of the questionnaires, there was an abbreviated version of a fatigue scale. So we had access to their fatigue levels. And as I said, the presence of hypermobility was not specifically associated with reported COVID-19 infection. But we found, so on the right, we have the COVID non-recovered, that nearly 30% of those 3,000 people, nearly 30% of the 914 who had not recovered from COVID had hypermobility, compared to only 20% in the nearly 2,000 who had recovered from hypermobility. And often, you know, journalists, they'll say, oh, you know, this is a big difference. But in science, we have to see, could that difference be due to chance? And what we found was that it was not due to chance, or it was highly unlikely due to chance, that just the presence of hypermobility alone meant you were 43% more likely not to have recovered from COVID. But of course, there could be all sorts of confounding factors there, couldn't there? So we adjusted for age, sex, ethnicity, socioeconomic status, education level, vaccination status, and number of vaccination. And we found that hypermobility significantly predicted not recovering from COVID with an odds ratio of 1.33, which basically means 30% more likely not to have recovered from COVID. Now, where are we? Sorry, my slides won't move on. And what we also found was that hypermobility significantly predicted having higher fatigue levels, and that the relationship between having generalized joint hypermobility and not recovering from COVID was likely due to fatigue. So what we did is we did the same thing as I've shown you before. We did that as a mathematical model showing that fatigue linked hypermobility to COVID recovery. Now, this is not unpublished data, so it's perfectly possible to share that. I'm sorry, obviously I hadn't removed that from the slides. So individuals with generalized joint hypermobility, approximately, so that's not necessarily symptomatic hypermobility, that's just generalized joint hypermobility, approximately 30% more likely not to have recovered fully from COVID-19. Now, not all of those people will have gone on to develop long COVID, but it's a significant index of interest. The observation is clinically important through its potential impact for understanding and identifying subphenotypes of long COVID, for screening and personalized targeted interventions, and more generally, greater awareness of hypermobility and its manifestations beyond the joints is needed for effective patient stratification and implementation of personalized medicine. So the vast majority, so nearly 90%, actually met diagnostic criteria for fibromyalgia, and nearly 100% met diagnostic criteria for MECFS. And this was really interesting. And we can't say that necessarily all fibromyalgia patients have MECFS and vice versa. Maybe it's just that the diagnostic criteria fail to capture the differences between them. But of course, we were interested in hypermobility. And what we found, which was similar to, where are they? In Sweden, I think, Brage and Bertelsen, we found that actually the vast majority of the patients, so 4/5 of the patients, met the criteria for what used to be called, in the alphabet soup terms, joint hypermobility syndrome, the Brighton criteria. But actually only 1/5 of those patients were aware that they were hypermobile. So really interesting, both fibromyalgia and ME/CFS, the vast majority of patients had underlying symptomatic hypermobility. And what was really interesting, sorry, my slides aren't moving, is that actually hypermobility features correlated with all sorts of pain and fatigue variables. So they correlated with the impact of pain or with the impact of fatigue, with numerous pain measurements, and with brain fog. And as I told you, when they came to the hospital, they had a number of blood tests. And it has been traditionally thought in the scientific literature that ME/CFS and fibromyalgia are not inflammatory conditions. And people are often told, oh, you know, your bloods aren't, you know, they're all perfectly fine. But what we found, now these are sort of scientific graphs, and I'm just going to show you the difference, is so on the right of each graph, we have the patients, and on the left, we have the comparison group, the people without pain and fatigue. And as you can see, there are significant differences in these common blood tests that indicate inflammation, ESR and CRP, between the patients and controls. And what's interesting is that the controls are very, very low on these blood tests, very, very low. You can see the healthy controls on CRP, the mean CRP is 1. Whereas the patients are basically at the edge of the reference range. So it's not looking significantly abnormal, but it isn't the same as the controls. So higher levels of baseline inflammation in patients with fibromyalgia and ME/CFS, who we know the majority of have in fact got symptomatic hypermobility. And we find that these individual markers of inflammation predict fatigue severity, pain level, brain fog. And when we put them on the tilt table, we found some really interesting differences between the patients and the controls in terms of what happened to their pain and fatigue levels. So again, these are some scientific graphs, but the patients are in red and the controls are in blue. And the tilt is the one on the left is before tilt, and the one on the right in each graph is after tilt. And you can see that the blue line, the control line, is basically a flat line, but there is quite a steep increase in the pain and fatigue experienced by patients as a consequence of the challenge to the involuntary nervous system, so the autonomic challenge. But what was really interesting is we also measured pain thresholds during the session, and there was no change in pain threshold during tilt, which means the patients weren't more sensitive to pain, they were experiencing more pain. So I'm going to talk, and this is going to be relevant for the long COVID data as well, about these two terms that we use in science. One is something called a mediator and one is something called a moderator. So sometimes we have a number of things that seem to be connected. And in the examples I'm going to give, we typically have 3 things that all seem to be interrelated. And a mediator is one of the things that seems to be explaining the mechanism of the relationship between the 2 other things. So that's a mediator. So it's the linking variable. A moderator is something that affects the strength and direction of the relationship between 2 variables. So it's not the mechanism, but it's an influence. So we're gonna come back to that in a minute. So what we found was that the patients, fibromyalgia, ME/CFS, were more likely to experience tilt-induced pain, and this was because of the number of connective tissue features due to their joint hypermobility. So not the number of flexible joints, but the number of connective tissue features. And we know that because these participants, we put through a number of diagnostic protocols for hypermobility. So this wasn't just the screening questionnaire, this was a full physical examination. And we found that in fibromyalgia and ME/CFS, the induced fatigue was in fact related to the background level of inflammation. So there's a QR code there, and you're able to read those findings. They're currently only published in abstract form, but we hope to have the full papers out this year. So in the second part of the study, people came into the brain imaging center and they had these brain scans. And we had some interesting results as a consequence. So as you can see here, the patients compared to the controls had more inflammation-induced pain than the controls and more inflammation-induced fatigue. And some of you may be familiar or not with this term called arachnodactyly, which is a feature of some people with hypermobility. So not all people with hypermobility have arachnodactyly. It literally means long spidery fingers. And if you can you see what I'm doing here, where I overlap my thumb with my little finger? That is one sign of arachnodactyly. Another sign is how I can protrude my thumb the other side of my hand. And arachnodactyly just means long spidery fingers and is a feature of something called Marfan syndrome. Most people with Marfan syndrome have arachnodactyly, but not all people with arachnodactyly have Marfan syndrome. And what we found is the inflammation-induced symptoms correlated. Now, this is a bit complicated. The inflammation-induced symptoms were related to the inflammation-induced inflammation. So the degree to which the inflammatory system responded to the inflammatory challenge, and that relationship was much stronger in the people with the long spidery fingers than it was in the people without. So we just bear that in mind for a second. And then we put this all together, remember the mediators and the moderators, and we find that being a patient is linked to inflammation-induced pain and fatigue, which is explained by the responsivity of the nervous system and influenced by the presence of long spidery fingers. So there is a model here that suggests that maybe there is a subtype of hypermobile person who is particularly sensitive to inflammation-induced pain and fatigue. Now, we presented that last year at a European Rheumatology Conference, and we have it in draft and hope to submit as a full paper shortly. But again, you can read the abstract from the conference at that QR code. Now, you're probably thinking, why is she talking about all of this when we've come to talk about long COVID? But you see, the thing is long COVID COVID itself is an inflammatory challenge. And all the people, not all the people, the majority of the people we were studying in this research, they had fibromyalgia, they had ME/CFS, and most of them were hypermobile. And I presented this work at a long COVID masterclass in London. And I said to the audience, is there anyone in the audience who has access to a long COVID cohort? And very fortunately, the speaker right after me, Professor Claire Steeves, who works at King's College in London, she was like, yes, I do. I've been running the Zoe app, which, as some of you will know, is now a diet app, but during COVID was a COVID symptom tracking app. And she said, we have a biobank of people who have signed up to report their COVID symptoms and infections. We can ask them about their hypermobility. And I said, yes, please. It's only 5 little questions. Do you remember those 5 questions that we talked about at the beginning? And we were able, there were ethics to be done and the questionnaire to be set up and various things. But that was how the Hypermobility and Long COVID project came about. But before we get into the nitty-gritty of that, I'm just going to tease you with some interesting brain imaging findings that we found. So there's all sorts of ways you can look at the brain with brain imaging. And what we're looking at here is how different parts of the brain talk to one another. So something called functional connectivity. So we looked at the functional connectivity of the whole brain using something called the Human Connectome Project acquisition and analysis. And we found that the change in something called network modularity, which is how distinct different networks are in the brain, how they're talking to other networks, that was different according to how many hypermobility connective tissue features you had under the old Brighton criteria. Remember the alphabet soup, symptomatic hypermobility. And then remember these mediators and moderators. What we found was that the change in how the bits of the brain talk to one another was related to the change in symptoms because of the connective tissue features. So what we're seeing here, and this was in response to inflammation. Remember the typhoid vaccination. So what we're seeing is that hypermobility seems to be playing a pivotal role in brain-body interactions in the presence of an inflammatory challenge. Now, that work that I have just described to you, I've summarized in about four or five slides. That was a huge piece of work with nearly 100 participants visiting our centres 3 times. And when they visited, each visit was between 3 to 5 hours. It was a huge thing for the patients. It was also a huge thing for all of the people who have been involved in designing and analysing the data. And so I just want to say thank you to all of the members of the team, because I don't want you thinking that that was just me. It was me making the graphs and thinking about the links. But the this has taken a huge team, and is thanks to our funders, Versus Arthritis and Action for ME and the former Fibroduct Foundation. So, as I said, we were talking about this at a long COVID conference, and people were becoming increasingly interested in people who were not recovering from COVID infection. COVID infection is now very commonplace, but unfortunately, a significant number of people continue to experience long COVID. And we've actually, there aren't up-to-date records because it's no longer being easily tracked. But at the last time they looked, the Office of National Statistics thought that 3%. So that is actually, there's quite a lot of people. So 3 in 100 people have not recovered from COVID. So this is the article that I'm just going to talk to you about, which was featured in The Guardian and has also been published, open access, for free. Not to us, unfortunately, it wasn't free to publish it open access, but in BMJ Public Health. So, is joint hypermobility linked to self-reported non-recovery from COVID-19? Case control evidence from the British COVID Symptom Study Biobank. And as you can see, this again was a large piece of work. So I must acknowledge Dorina Kadar, Lisa Quat, Alan Hackham, remember his name from the questionnaire, Nicholas Gould, who some of you will know is a POTS physician, the whole group behind the COVID Symptom Biobank, Vicky Bauer, who works at King's coordinating the biobank, Nathan Cheetham, Claire Steeves, my colleagues Hugo Critchley and Kevin Davis. So, something's happened. I'm just going to briefly say, because of the links with SEDSConnective and also the emerging research, that we know that there is a lot of commonalities between hypermobility and neurodivergence. And we know that neurodivergent people not only experience increased barriers to healthcare, this is colleagues Mary Doherty and Sebastian Shaw, but they are also more likely to have adverse outcomes. We know that hypermobility is associated with autism and ADHD, and and pain. And we did a study explicitly linking that. This has now been viewed about 140,000 times. And what we found was that the neurodivergent people had more pain. They had more symptoms of orthostatic intolerance, so that's difficulties with the involuntary nervous system, and they were more likely to be hypermobile. So they were 4 times more likely to be hypermobile if you were neurodivergent. And up to nearly 80% of our autistic and ADHD females were hypermobile. This is generalized joint hypermobility. And we found that their symptoms tracked with their degree of hypermobility. So again, thinking about what's going on here, the presence of neurodivergence and symptoms seems to be linked to hypermobility. So we must think about joint hypermobility in neurodivergent people and think about neurodivergence in hypermobility and make sure our provision, our services and strategies are hypermobile and neurodivergent friendly and accessible. So just finally, why is it important to think body-brain? Well, Embracing Complexity have told us that nearly half of all neurodivergent individuals feel that their treatment of a mental or physical health problems is worse because they were neurodivergent. And our own work that we've been doing locally tells us that neurodivergent people and their families struggle for years to get an assessment and diagnosis for both mental and physical health problems, that they feel a strong sense of being dismissed, misbelieved, or overlooked when interacting with professionals and institutions, and that they repeatedly encounter poor understanding and or few or no adjustments for their needs within healthcare and education, which is obviously precisely what SEDSConnective aims to improve. So the other thing is, some of you may have seen on Twitter, we have some upcoming research due out this summer linking neurodivergence to emotion regulation through proprioception in the presence of hypermobility. We know that conventional emotional medication-based treatments do not work for all. This may open up opportunities for novel avenues, so brain-body interventions for personalized treatments for common mental health problems and also possibly for physical health problems. And I just want to say and acknowledge that hopefully all of this research data and the work that charities like SEDSConnective and others are doing will help raise the profile of hypermobility. And this is an article that was published in 2023, Clinician-Associated Traumatization from Difficult Medical Encounters, results from a qualitative interview study on Ehlers-Danlos syndromes, which they call clinician-associated traumatization. So we have some exciting projects that are collecting or nearly finished collecting data at the moment. We've just finished our study in the brain scanner of brain fog in people with postural tachycardia, inducing a autonomic challenge in the brain scanner. Our ACF has finished his study Float Rest, which is looking at intraception and float tanks for people experiencing fatigue. And our PhD student, Beverly Darkin, is looking at brain fog in pregnancy and menopause. So I think that is before we start the questions, thank you to all of the participants and the research staff, particularly members of the Sussex MECFS Society and the former Sussex charity Remember, all of the staff at SISC and CIRU, and the many, many people who have contributed to this research, and particularly Professor Hugo Critchley and Professor Kevin Davis.
Thank you. Thank you, Dr. Eccles. It was absolutely wonderful. I was just saying I need to reflect on some of those slides myself quite a lot. We do have questions. I haven't checked them all, but I've got some already sent in. So if I may, I might just read some of these, and then others might want to see if they other ones are there. As we said at the beginning, we cannot, Dr. Eccles will not be giving any medical advice. One question is, are symptomatically hypermobile people also prone to other post-viral fatigue, or is there something particular about COVID?
Well, I hope that actually that was addressed in the presentation.
I think it was.
In that we found that the vast majority of people with ME/CFS or fibromyalgia, and both of which are thought to have a post-viral element, 4/5 of them had symptomatic hypermobility. Half of them had generalized joint hypermobility.
This is an interesting question. What does COVID do to our connective tissue that makes us probably, or the data you gave, more prone to long COVID symptoms?
Well, that is the $64 million question, but I think there is an interaction between the extracellular matrix, so the connective tissue, the autonomic and the inflammatory system, meaning that you're more likely to experience autonomic problems and maybe more likely to experience inflammatory problems. And you may already be predisposed to this because of having connective tissue issues. And we know that up to 70% of people with long COVID go on to develop, they may have actually had it before but not realized, postural tachycardia syndrome, which is the one of the problems with the autonomic nervous system that we were looking at in the mechanisms of chronic pain and fatigue study.
Thank you. I need to know what else is coming, what else needs to be done on this?
Well, there's lots of things that need to be done. I can't promise you that it will be published, but it's currently under review with the BMJ journal. We have we have research looking at the relationship between childhood neurodivergent characteristics and later chronic fatigue. As I said, that is currently under review. So hopefully will be published at some point in the near future. I think the main thing really is joining the dots. There's obviously a lot of other biomedical work looking at things like blood stickiness, microclots, all sorts of things along those lines. But I think it's really important to acknowledge these brain-body connections and that hypermobile people are not, making things up, that there are all of these reasons and links for experiencing these difficulties. And I think it's so important to continue to put out the biomedical research because, and we say this in the BMJ public health article, long COVID risks, although it's a huge public health challenge, it risks people and doctors in particular thinking, this is just, this is functional, or this is somehow a psychiatric manifestation of something else. And so it's really important to have all of this brain body work that shows the context.
Yes, it would be fascinating to include children as well. I think it would be key. Question on the chat: could COVID cause an increase in venous compressions in a hypermobile population, leading ... POTS, postural tachycardia?
I think it could lead to it definitely could lead to postural tachycardia syndrome. As I said, the majority of patients with long COVID have some form of demonstrable orthostatic intolerance to have postural tachycardia. The exact mechanisms are likely to be multifactorial. So they may involve the cardiovascular system and venous return. They may also involve autoimmunity. That's when the body attacks itself, and small fiber neuropathy. I think there are lots and lots of different things going on. But the thing is if you identify the presence of POTS in long COVID, there are all sorts of things that you can do to try and help manage POTS, which may well then help with long COVID symptoms. So it's really important to look out for it, because we know that there are ways to help support people with POTS, and maybe they are helpful in long COVID too. That's the whole point of identifying these types of people.
Yeah, that question came up as well. What can we do? And I think you've answered that one. One question slightly differently. Excuse me. What could these new interventions look like incorporating gut microbiome neurodivergence and hypermobility?
Well, I think the thing is so we have colleagues in medical school who've recently, I think, published on the role of probiotics in improving mental health, and it probably improves physical health as well. I think taking a brain body approach means that you can tackle things in all directions. And there are other things. I just see a question popping up from Michael about the role of mast cells. I haven't specifically mentioned mast cells, and that's for a number of reasons. I absolutely believe in the relationship between hypermobility, mast cells, and the involuntary nervous system and post-viral fatigue. Mast cells are really difficult to measure. From a research perspective, absolute nightmare. And we hope to incorporate thinking about mast cells, probably through using skin biopsies and then staining for mast cells in future research. So some of you may have attended our public engagement event that we did last autumn about next steps for the mechanisms of chronic pain and fatigue research. And one of the things that we were thinking was to do a mechanistic trial of low-dose naltrexone. I'm also thinking that we could not only look at low-dose naltrexone, but there's been reports about an ADHD treatment called guanfacine being helpful for long COVID. So I think we may look into that as well. But it would be really nice if we were to start people with long COVID or fibromyalgia or ME/CFS on a treatment trial to track mast cell activity before and after treatment. I would very much like to be able to do that. It's just thinking it through from a practical step. But of course, if we think mast cells are in the mix, we know that some people respond well to antihistamines, which stabilize mast cells. So that's another thing alongside POTS management is recognizing and understanding the role of mast cells is really important.
Thank you. Yeah, so I mean, and this question comes up a lot, of course, and you brought it up on a paper, how a lot of people have felt disbelieved having hypermobility, and of course with other conditions like ME, CFS, possibly not fibromyalgia so much. But do you think long COVID is disbelieved as well?
I think it varies hugely, but I think there are a lot of people who are really struggling to be taken seriously, including people working in the NHS who have, long COVID is essentially an occupational exposure, and they are struggling to retain their jobs and get the support that they need. I think it varies hugely. You talk to one doctor and they'll have their own opinions and another doctor, but I don't think that this is currently high on any policymaker's agenda, the role of long COVID or the impact of long COVID, when we know that it is a huge problem affecting 3% of the population, which is really, that's one person in every classroom. That is, at least one person in every office. It is not something, COVID has not gone away. Long COVID will not go away. So we really need to raise awareness of it. But the thing is, in some ways it's a new thing, in some ways it's not a new thing. ME/CFS has been around for ages. I'm not saying that it's necessarily the same, but there's been a whole host of attitudes towards ME/CFS, and I suspect there is similarly mixed attitudes towards long COVID.
This came up quite a lot, but you have actually touched on it. Can long COVID exacerbate autoimmune conditions as well? But I think you did touch on IBD and some others as well.
Well, yes. I mean, I think it's absolutely theoretically possible that could be the case. And we know that hypermobility, there isn't a huge amount of research about it, but there is enough to start taking it seriously that hypermobility is probably associated with a number of autoimmune conditions.
There's so many. A question related to research: what evidence, of any, has been found on heart, excuse me, heart-related incidents, either in hypermobility or long COVID?
Well,
I'm
and
not
there's
quite
a
sure.
whole subtype of
Vaccination.
there's a whole subtype of COVID that's had cardiovascular um, manifestations, and I remember when I was at that long COVID masterclass, which is available online on POTS UK, the long COVID masterclass. There was a whole session about the cardiovascular complications. I think the thing is that there are probably distinct types of long COVID. That, long COVID is a single unified thing, and that maybe hypermobility predisposes towards a long COVID in which things like fatigue, dizziness, and POTS are prominent. It may be that other conditions predispose to things in which cardiovascular difficulties are there. But to truth be told, we really don't know a huge amount. But that POTS UK long COVID masterclass, there are some excellent talks available on YouTube.
So do you think it's a bit like I see people with hypermobility and neurodivergence, we have all these different sort of traits or weaknesses or challenges, but we all go in different areas. So maybe that's the same with long COVID.
Yes, absolutely. Not all hypermobile people are the same. Not all neurodivergent people are the same. There will be different factors in different individuals that predispose them to both strengths and challenges.
And I think that's very hard for people to see outside. Well, you've got that, you should have that, and that's why sometimes there's disbelief. This question comes up a lot. How do you get diagnosed with long COVID? They said they can't differentiate. It's a sort of general one, but how do you get diagnosed with long COVID?
Well, for people in the UK,
I think so, yeah.
presume you go to your GP and you see if you can be referred to the long COVID service. I mean, I'm not sure that it's the diagnosis that's absolutely critical, because you've had COVID and then you've not recovered. But I think it's about accessing the right support. But I think I don't work in a long COVID service. I'm not adjacent to that. I think that some of those services are closing down. I know that if you think you have ME/CFS or fibromyalgia in Sussex, there is a Sussex ME/CFS, not fibromyalgia, Sussex ME/CFS service, and there is a very good, but they helped us very much in recruitment, the Sussex ME/CFS Society.
I'm going to read it out exactly as it is. Do you think long COVID might be causing an increase in enzymes that break down connective tissues?
Well, I think there is an argument or a debate about, does COVID worsen connective tissue issues in people? So, I mean, some people say, has COVID made them hypermobile when they weren't before? Now, this is a genuine question, and we are actually doing research about this at the moment that we're currently analysing. I suspect that it has increased connective tissue issues in people who are already predisposed. But again, we need more research. But no doubt, inflammatory mechanisms can probably interact with connective tissue. And there's actually a lot of connective tissue in various inflammatory molecules. So complement has a number of collagen bits in it.
Collagen bits, that's lovely. Would home ESR testing help people in decision making, timing to take vaccines? Not quite sure.
No, I think the thing is those results that I showed basically show that people with ME/CFS and fibromyalgia, they were more likely to be on the border of what is considered normal. And then the controls were like clear water below them. I think that it's like the false positives and the false negatives. You don't want to overly rely on a test for anything. You've got to take into consideration the clinical picture. What I think we need to promote is to other healthcare professionals who are interpreting these results that anything that's near the reference range should be investigated if there are clinical symptoms as though it was above the reference range.
Okay, and we're coming near the end, so I'm going to do one last question. Is there a role of peptides, like, I might say this wrong, BPC-157 for connective tissue recovery?
I'm afraid that is not something I'm sure about. I am not familiar with this peptide. I suspect that there are all sorts of things that might be helpful. I don't think that drinking collagen or like bone broth type of things are going to necessarily change or improve your connective tissue. And I would be wary of people selling you things that seem to do that. But there is so much more that we need to understand. This is just the tip of the iceberg, but hopefully it's the start of raising awareness, and it's the start of conversations with policymakers, with doctors, with medical students, with across health professions about recognizing the importance of hypermobility to so many common things.
Yes, and I absolutely concur with that, particularly with children and attendance in education. If they've got these issues, I think it's crucial, and hopefully will be changes. So I know if you have any more questions, I'm sure Dr. Eccles will. You can contact her on her details, which are at Bendy Brain and her email and so on. If we haven't asked them, I apologize, or you can come to us and we'll send them on. I absolutely, it's wonderful. Thank you so much for coming. I can tell the team are really, really excited by this. And we were over subscribed to this, but you will get recordings in due course. Excuse me, and we would love to do more, and we will be following, of course, our patron research and the other team members. We want to thank you all for doing all this research for us, because it's very much needed, and it gives us hope. I think that's the one thing that comes, there is something being done, and that's what people want to hang on to and believe, and then we can, as a charity, help hopefully transform other areas. And so really big thanks, especially on a Sunday, coming here and giving up your time. If you would like to know more about SEDSConnective, please look at our website, sedsconnective.org, and we are voluntary and we are user-led, so please feel free to donate so we can do much more. And thank you for all the team here, to Deb, Rebecca and Yvonne, and some other team members behind, and we're all a lovely team. So do join us next time. Thank you. Hello, and welcome to our SEDSConnective presentation with Dr. J Eccles on long COVID and hypermobility. SEDSConnective stands for Symptomatic Hypermobility, EDS, HSD, Neurodivergence. We started in Sussex, but we're now a global user-led voluntary charity. I'm Jane Green. I'm an educationalist, founder and chair of SEDSConnective, and also keynote speaker for neurodivergence and hypermobility. I'm not a professional host, so do bear with us. We have a lovely team supporting us today as usual. So we're absolutely delighted to have Dr. Eccles here today, following the latest findings from a study which was published in the BMJ Public Health with the British Sussex Medical School and the King's College London researchers. And this found that people with hypermobile joints were about 30% more likely to say they hadn't fully recovered from COVID-19 than those without. Anyway, I will introduce her now and she will explain much more. She is a consultant psychiatrist in the Neurodevelopmental Service at Sussex Partnership NHS Foundation Trust. Having trained in medicine at the University of Cambridge and Oxford, she completed integrated academic training in psychiatry at Brighton and Sussex Medical School, where she undertook an MRC clinical research training fellowship. She is now a reader in brain-body medicine at the BSMS Department of Clinical Neuroscience, where she leads prize-winning research on a broad range of projects that link differences in the body to a variety of physical and mental health conditions. And she is particularly interested in the emerging link with neurodivergence. She is a passionate educator and committed to public engagement. So I now want to welcome Dr. Eccles to our meeting, and we will go ahead. And thank you all for joining us today.